The current budget, we have about 44% of the current budget is state, and the rest is 11% is federal, and the rest is ThinkCare, which has state match in it.
And how much of the DCS budget makes up the state budget? What percentage of the state budget is DCS's?
Of the entire state?
Yes.
Yeah, I have to get back with you. Our budget is $1.5 billion, and the state is much,
It's
I don't know
56 billion. Okay, that answers.
exact amount, but it was $1.5 billion.
Thank you. I just asked one of the mathematicians out here in the crowd. I'm just kidding. Thank you for that. I appreciate it. Thank you, Mr. Chair.
All right, thank you. I'm going to go back just for a second. I want to talk about the private provider residential case management. How do contracted case managers differ from privatized case management services for children in temporary and transitional custody?
Are you asking what the difference is between the contracted case managers and the residential case
Yes.
managers? So the contracted case managers are serving our foster care families and carrying cases, which is helping us reduce the caseloads and helping us remain in compliance, caseload compliance. The new residential caseload case managers are going to actually work out of the transitional homes and help us manage the behavioral issues that are going on in the transitional home. So they will be specially trained residential case managers. Our folks are not necessarily specially trained for residential. There's a difference between case management and residential, especially trained residential personnel. These people that are coming on are going to be specially trained in residential case management. And so they're going to be working out of the transitional homes and helping our case managers manage the behaviors that are occurring in transitional homes. Much like what Representative Hawk was talking about, we really hope that between the specially trained residential case managers, the behavioral health specialists that we have hired, and the program coordinators that we have hired to sort of manage all of this, it will reduce the burden on our case managers exponentially.
So if you were to look at the salaries between the state caseworkers versus the private caseworkers, case management workers, what would that look like if you were to compare the two? Is it pretty comparable?
We think it's pretty comparable, and I know it looks like a pretty big number, but that big number also encompasses their salary, their benefits, their supervision, and the overhead cost for the company.
Okay, and then you mentioned the caseload for state employee case managers, but I didn't hear you actually give a number. What is the caseload right now?
Well, it varies region to region, and it
Okay.
varies program to program.
Okay.
There are, I think, I'd have to look at it today. There are 2 regions right now in Child Protective Services that are outside the caseload compliance. Davidson County has always been our hardest hit region. They are hovering in the low 30s. For reference, when I came on in September of 2022, the caseload average was 96. And they're right around 32, 34 week over week right now. So we've cut that into 2/3.
Okay.
South Central, which is just south of here, they are in the mid-20s in child safety. In the child programs area, the only area that I would say is out of compliance is in Northeast, which is in Representative Hawk's area. That sort of high Northeast area. That's the only area that is really out of compliance. And they do have the residential case management up there. That is one of the areas where we do have residential case management. So that's why it's so important that we continue that funding, because without those case managers up there in that particular area, I think we would be even further out of compliance.
Okay. And then my final question before we'll move on to the next member. Who's liable when a private case manager, when they make a mistake? Who's actually liable for that? Is it the state?
Yes.
Okay. All right, next speaker will be Representative Hicks of Washington.
Thank you, Mr. Chairman, and thank you, Commissioner Quinn, for being here. And, you know, you have a tough role. It's a big issue, and you've done a lot of work. There's still a lot of work to go, but you're doing a great job. So thank you for being here. And you had mentioned the assessment treatment homes. So I want to talk about that just a little bit. The proposed budget has $11.3 million in it to extend the beds so you can serve 48 new, I guess, kids in that area. So is there a limit to the amount of time a child can stay in those assessment treatment beds?
I'll take that one. Sir, we would prefer that number be right at 30 days. I shared in my presentation, we're at 38 right now. So we're continuing to work with our provider agencies that are delivering this service to get that number down, improve, or to expedite their assessment work delivery to us. So we're right at 38. We want to be at 30.
So you're right at 38 and you're trying to get that down to 30 days is what the goal is.
Yes, sir.
Okay. How many existing beds are there for assessment currently?
Yeah, there are 72 beds out there right now.
Okay. Are these distributed all across the state?
Yeah, so to some degree, yes, sir. We just opened the facility Commissioner Quinn mentioned in Bartlett in Shelby County. We have a facility in Gallatin, and then we have programs clustered here in Nashville. But part of the real estate plan moves those into the grand regions of our state so that there is better distribution of them. For expedience purposes, we did a lot of work right here in Nashville because the real estate and buildings were available to us, and we knew we needed to move expeditiously.
Are most of those beds through a private provider?
Yes, sir. They're all delivered through a private provider with the expertise to do the work.
Is it the same provider all the way across the state pretty
It
much?
is. Yes, sir.
Right now it is.
And are you happy with that provider? Is everything going well?
Yes, yes. I mentioned we'd like it faster, right? To shorten that length of stay. But that agency has been a good partner to us. We're one of the first states, if not the first, to dip our toes in work like this. And so some of it has been a learning experience, and we have course corrected as we've gone along. But yes, sir.
Thank you for that. Thank you, Mr. Chairman, and thank you for what you're doing. And I can see where that's very helpful, what you're forward thinking in that. So thank you very much.
All right, thank you. Next on the list, Chairman Vaughn.
Thank you, Mr. Chairman. Thank you all for being here. I want to revisit something that my colleague, Representative Hale, touched on a little bit, and that's the child advocacy centers. And I'm going to, when I question the raise that y'all are proposing in your budget for this, my question is it enough? Given the fact that we've been flatline funding this since 1996, and when we see, particularly in the Shelby County area, what a great job that they do advocating for children and being in traumatic situations. My question is, I know you mentioned, Commissioner, that we're funding what they requested, but I think that when these are some of the best invested dollars that our state spends. So are you confident that this money that they're asking for is enough to make up for all the years of inflation that they've been doing, or are they just doing such a bang up job of fundraising and seeking other sources of revenue for them to adequately provide the services they do, or could we enhance that if this was a different amount of money?
I can only go by what they asked us to ask for. I would say that I think it's fair to pay them what we pay our case managers, and I would not advocate to pay them more than what we pay our case managers. given what they do and what our case managers do. We advocated strenuously for our case managers to get, pretty substantial raise. I know our start salary is still 38,000 for our case managers. Now I can go to the midpoint at 48,000. And right now we're still in a hotspot salary at 50,600. But if we were to go back to a start salary, we'd be at 38,000, and forensic interviewers are at 35,000. Now we're budgeted by the legislature at 38,000. And so I have to make up in my budget to the 48,000 if I hire at the midpoint, or to 50,000 for the hotspot salary. But our budget, our starting salary for a DCS case manager is 38,000. So it's still only 3,000 more than what a forensic interviewer is. And I'm not advocating for a $3,000 raise for them. I'm advocating for much more than that.
You recognize Chairman Vaughn.
Thank you for that. I appreciate that, because with that being tied to internal sources and internal costs that you have with your employees and your personnel, that makes a lot more sense to me. So
Yeah.
I was trying to figure out where this number came from, and now that you cleared that up, I do appreciate it. Thank you very much.
All right, thank you. All right, I have no one else on the list. So thank you, Commissioner. Thank you and your staff for being here. Thank you for your presentation. And I know it's already been said, but thank you. You do have a very difficult job, you and your team across the state. And I do want to say thank you for the service you provide. So
Thank you, Mr.
thank you.
Chairman.
All right. Next, we will ask the Health Facilities Commission and Director Grant if he would make his way, he and his team would make their way to the front. What kind it was. Then I got. And Director, we've got a new system, so we will actually control the microphones now. So thank you all for being here. And again, if you'll just make sure that you're recognized, and we'll make sure your mic is turned on in case you all want to go back and forth. But thank you for being here. Welcome. And if you'll just begin by introducing yourself as well as your staff member there to your right. So thank you again.
Thank you, Mr. Chairman. My name's Logan Grant. I'm the Executive Director of the Health Facilities Commission. With me is John Carr, our Director of Finance and Administration. I'm very happy to be here, and I really appreciate all handling my mic for me. That'll help me focus on the presentation. We're very grateful that of our budget requests to the governor's office, they were able to fund two of our requests, one for $4 million non-recurring for a new licensure system. We are presently piggybacking off of the Department of Health's LARS system, but they're in the process of developing a new system which would not include the functionality that we require for the regulation of healthcare facilities. So we're very grateful for that. Additionally, they funded some positions for accounting support. Now, although the funding for these positions would go to us, these positions will actually be housed in the Division of Accounts with the Department of Finance and Administration. And what they'll be doing is helping us do our reporting to CMS and draw down federal funds. So we're very grateful for that. We did have some cost increase requests, which were not included in the governor's budget. Number one was our high priority complaint unit. Now, what this would do is would form a group of surveyors who could investigate complaints of healthcare facilities that would be centralized in the state, and they would be able to respond across the state. And what this would help us do is not only help us be more responsive to, complaints that might involve immediate jeopardies or risks to patients, but would also allow us to reduce the disruption to the recertification surveys that we're very behind on. See, our surveyors also have to go out and do recertification surveys for healthcare facilities in the state, and we presently have a backlog of those because of the increased number of complaints that we have to investigate. So we requested 4 additional positions for a high priority complaint unit that would not only help with that, with complaints, but also with recertifications. We requested some additional positions to help us with the CON reform implementation. That legislation was passed last year, and that funding would be through dedicated funds through the CON program. Item number 3, we request some additional licensure staffing. Now, this is for not for explicitly surveyors, but this is administrative support and plans reviewers and life safety inspectors. We have not had an increase in the number of folks that are reviewing plans since the 1990s. And we have a lot more plans that we are reviewing on an annual basis. So we had requested some additional support to be able to perform those functions. Additionally, we had requested some more legal support because our litigation attorneys are presently handling about 60 cases each. And so we were hoping to get some additional resources to be able to deal with those. Additionally, we requested an infection preventionist. As we all know that from COVID, there's a lot of risk to patients when there's an outbreak in a healthcare facility. So we wanted to bring on somebody with some expertise in that would help us adopt policies and perform and do training for providers and help our state be more prepared for those. We were requested to propose a 1% cut to our operations, which we provided to the governor's office for a total of $153,000. And I just kind of like to talk a little bit about some of our increasing workload. As y'all can see from the graph, that graph is the number of quarterly complaints that our office received. As you can see in 2022, in quarter 4, it began to spike, and that is a result of changes in the state operations manual from the Centers for Medicare and Medicaid Services. And that results in, like I said, a lot more complaints, which all have to be investigated by our surveyors. So our workload has increased tremendously. Presently, it's about a 54.2% increase from 2022. As you can see here, about our recertification backlog. We were behind on those when we merged or when the merger occurred in 2022. We are making progress and reducing those, as you can see in quarters 3 and 4 of 2024. We are working through that backlog, but we do believe that more additional resources would help us get through that more quickly. Speak a little bit on how we're doing with CON reform. So the first services that are scheduled to come out from CON regulation will occur on December 1st, and that will be NICUs, burn units, and PET and MRI units. We formed to establish the quality measures that they would be now subject to. We formed some technical advisory groups of providers, and we've been very, very pleased and grateful for the input that we've gotten from and engagement that we've gotten from the provider community. They've really helped us navigate that, and particularly with the NICU units, we think that some of the new standards that will be put in place will really materially improve the care that's provided to some of our most vulnerable patients in the Tennessee. So some of the NICU recommendations, which will probably be approaching some of y'all after this. So one reason why we will have some expenses that were not requested through the regular budget process is that we had to make our request to the governor's office or submit those in September, but we didn't have the technical advisory group recommendations completed by then. Those were only completed this past January. So we will be in touch with some of y'all about some resources to implement this. Of course, if those resources are not available, then we can pivot into other directions. It shouldn't. It's something that we've made some contingency plans for. Some of the recommendations for the burn unit is requiring that all burn units become accredited by the ABA within 5 years of licensure. Similarly, we are going to be requiring accreditation for the PET and MRI units. And that concludes my statements. Happy to answer any questions.
All right. Thank you, Director Grant. We do have a couple members on the list to ask some questions, and we're going to begin with Representative Garrett. Representative Garrett, you're recognized.
Thank you, Mr. Chairman. Thank you all for being here. You could imagine my questions will be around the CON. So you just mentioned in your presentation regarding Public Sector 985 and what is in the queue to be eliminated under CON. So my questions are going to kind of revolve around that. You mentioned the NICU's advisory groups and their recommendations, and you also said that they suggest for the share of the cost of up to 50%. So my question regarding that is, what are the recommended projected re-verification rates for the NICUs? And then following that, how do we propose re-verification rates compared to what NICUs were paying under CON? And I've got some follow-up questions after that, sir.
Yes, sir. Thank you for the question. Presently, under CON, there's re-verification is not required, so that is currently not being performed as a requirement of state law. So that would be something that is new. In terms of how much we expect that to cost, we are still in the process of evaluating that. We are also in the process of contracting with a neonatologist to help us prepare some surveyor tools, and basically to find ways to operationalize that. As I said, the recommendations were only finalized in late January, so we are moving through very quickly to process that and be able to provide accurate information to you, but we don't have it at this time.
In relation to that, did any other facility advisory groups think the state should share in the cost of the re-verification? And then in conjunction with that, why should the state share in that cost for re-verification?
Re-verification is unique to NICUs because what it is essentially is when presently when a facility provides NICU services, they identify as a level 1, 2, 3, or 4, but there is no verification process done by a third party to make sure that they are meeting those standards, and so that would be unique to NICU and would not be something that would be applicable to burn units or imaging services.
Okay. You led me right into a segue to my next question regarding burn units. You said, I think earlier, that the advisory group recommends that they be given 5 years from when they are licensed by the commission to become accredited. So my question is, why should an unaccredited facility be given a license initially?
So in order to become accredited, you do have to be operating, and a lot of these accreditation requirements involve staffing. And so you have to have you have to be able to hire people, and I believe that when the accreditation folks come in, they're also looking at some outcomes data and things like that. So it's something that needs to be I think the accreditation process can take different periods of time for different types of services. And I can't remember exactly what the timeline was for the burn units. But I would say that there's presently only 3 in the state. We aren't aware of anyone who's intending to open another one, but we believe that it is a reasonable amount of time to obtain that accreditation, because there are, of course, other quality standards that they have to meet through licensure. It isn't as if they're not being regulated in the interim period.
So I assume that's why it's 5 years.
Yes,
It
sir.
takes time to build that up. So that just seems like a long period of time not to be accredited. Finally, and then I'll wrap up. With an already high caseload for each employee and regulations continuing to increase, does the commission feel that it's adequately inspect and address concerns in each of these facilities to meet the standards moving forward?
I'm sorry.
With an already high caseload for each employee and regulations continuing to increase, does the commission feel that it can adequately inspect and address concerns in each of these facilities to meet federal standards moving forward?
I believe that let's put it bluntly, if CMS would stop adding things to our plate, we could probably get it done.
But right now you're restrained.
We are very strained, and right now it's very challenging because, for example, we haven't received an increase in federal funding in about at least 10 years. We're currently capped at the amount of federal funding we get, I believe, at $9.25 million. The states had to, of course, pick up the remaining tab. For example, on the rising salaries of our surveyors. Our surveyors have to be licensed healthcare professionals, and as y'all know, the salary, in order for us to be competitive in the labor market, we have to increase our salaries. There was that market study that was done. The state taxpayers had to pick that up, and we got no increase. We got no corollary increase in federal funding. So And during the previous administration, there were a lot of additional regulations that were added onto our responsibilities, which we are, as you saw from the graph, drastically increased our number of complaints. And those complaints all take away time from that we could be doing recertifications or other options. So I'd say, yeah, we're in a tough spot.
Director, thanks for indulging my questions. I appreciate it. Mr. Chairman, that's all I've got.
All right, thank you. All right, next member on the list is Representative Capley. You're recognized.
Thank you, Mr. Chairman, Director. Good afternoon. Got a few questions here. Just going back to the presentation. Complaints have risen since 2020 and the number of recertifications performed by the commission has decreased since 2022. To start off, what's the most common complaint received by the commission?
I'd say, I can get you that data. I apologize. I can't. We have some good statistics on what our most common complaints are. I know that some of them involve, actually, I couldn't be able to speak off the top of my head, but I can definitely get you that data. We have a lot of information on that.
Okay, awesome. Yeah. What's the current caseload per employee for complaints and inspections?
I don't have a statistic for the number, and it's also hard to compare apples to apples in that, because sometimes you'll go out to a facility and there will be high level, not all complaints are equal in terms of, their severity or the amount of time that it takes to investigate them. But I can tell you that all of our folks are, the vast majority of our folks are putting in a lot of overtime to try and work through our backlog of recertifications, and also just to meet the staggering demand of complaints as they're coming in.
Sure. Going on off the overtime thing, how many sites typically from where y'all are at, do the employees inspect annually? Just ballpark.
I would say, I think last year, I want to say we were in about 90 to 100 different facilities.
Okay.
Over the course of the year.
Okay. Next set of questions, going off of recertification. What's the process for recertification? What does that look like?
So recertification will be a survey that's supposed to be done, I believe, once every 15 months. As you can tell, we're far behind on some of these. And what we're trying to do when we go out to those is not only do the recertification, whereby we do an inspection of the facility, we talk to our surveyors will get a sample of the patients, talk to them about their experiences, make sure that the care that's being provided is adequate. They will inspect they have a lot of different regulations that they're looking for. They'll check out where the food is made, where the patients stay, check the policies for the staff, make sure the staff have been trained that work there, make sure they have an emergency preparedness plans, things like that. But while they're also there to try and be efficient with our time, we also have them investigating complaints on the facilities. So we've kind of put those two things together. So when our folks are in a building, they'll be trying to knock out both at the same time.
Okay. And I know you said that maybe in certain cases y'all have been behind, but what are the consequences usually associated with an overdue recertification?
Well, the biggest thing is that there can be some risk to patients if we're not out there making sure that folks are performing to the level of care that we expect. At that said, in a lot of places we are going out and investigating complaints. So if we do get a high level complaint from a patient, that has to be investigated by law within, I believe, 48 hours. So if we do hear about something, we prioritize and we get folks out there immediately. But there is some risk to the patients that we aren't able to get out there for recertifications on the basis that we're on the schedule that we're supposed to.
And last question, Mr. Chairman. Prior to 2022, how many recertifications were performed annually, and was there a backlog during that time?
I think during what year? Sorry,
prior to 22.
Prior to 22, yes, there was a backlog. So there was when we were under the executive order during COVID, there were no recertifications done. So we kind of inherited that from the COVID epidemic.
Thank you, Director. Thank you, Mr. Chairman.
All right, thank you. Next on the list, Chairman Hawk, you recognized.
Thank you, Mr. Chairman. Director, it's great to see you. You've known each other a long time, so I appreciate the work that you're doing. Tell me something, as we're looking, a lot of questions about the high priority complaint unit and the funding that is not coming there. Tell me, how can we get to a better place within the general public as to, if this happens, then who do we contact? Because as constituents reach out to us, we'll think Department of Health this, Department of XYZ that, the Department of whomever this. Absent spending money, how can we do some type of PSA, or at least get the information to my colleagues and myself that if this happens, then contact us at health facilities. If that happens, then contact Department of Health. Is that something you think about as a team, or am I just off base completely? Tell me a little bit.
No, sir, that's a great question. And since we took the regulation of health facilities from the Department of Health, that does come up sometimes. And sometimes sometimes it's not exactly clear, until Department of Health and us get together about whose responsibility it is, particularly when you're involving, clinics that are under a health provider's license that may also perform services that we regulate. So it can be, sometimes it can be complicated, but I do think that we could help y'all out by working with the Department of Health on a one pager that could help, provide y'all staff. If this comes up, here's some clear lines of who y'all could reach out to. And we'd be absolutely happy to do that.
Chairman Hall.
And thank you. I think that would be of great benefit to our members and the staff, because we're fielding questions, and even with folks that have been here for a long time, as in the whole scheme of things, a fairly new organization in what you're directing at the moment. I think that would provide great value to our constituents and to our staff, as we can have a direction to go, that open door, who the open door for the issues are. So thanks for consideration, and look forward to hearing more about that. Thank you, Chairman.
Thank you, Chairman. Next on the list, Representative Love. You're recognized, sir.
Thank you, Mr. Chairman. And I'm actually going to reference the screen for increasing workload. And the second bullet point there says in 2024, there were 6,216 complaints triaged by complaint intake staff. Do you know what attributed this increase?
Yes, sir. Chapter 5 of the State Operations Manual, which is the State Operations Manual, is CMS's manual that it sends down to states who operate as the state survey agency on their behalf. Those changes drastically increased. It requires several things, among them facility reported incidents. Now, that's where if a facility, if an incident happens at a facility that involves a patient and puts them at risk, even if the facility has already resolved it, they still have to report it to us. Additionally, there are, in some cases, we get duplicative complaints that our complaint intake unit has to reconcile because we're getting them not only from our, through our phone lines or email communications, we're also getting them from other departments and agencies. I would like to just point out, though, that just to be clear, the increase in complaints does not indicate a diminishment of quality of care that's being provided to Tennesseans. Okay. It's really more of a procedural reporting issue.
Okay, thank you. Thank you, Chairman.
All right, thank you. All right, members, I have no one else on the list that would like to be recognized. So, Director, thank you very much. Thank you for being here. Appreciate you and your staff, and certainly appreciate your presentation. Without objection, members, we will now be back in session. We're back in session, and that does complete our calendar for today. Just a reminder that budget hearings will resume tomorrow at 8 a.m. in House Hearing Room 3. Please keep your applause down. Do we have any further business coming before the committee? If not, without objection, we stand adjourned.